Hello, this is Dr. Philip Mease, Director of Rheumatology Research at Swedish Medical Center and Clinical Professor at the University of Washington School of Medicine in Seattle, Washington. I will be discussing the abstract Efficacy and Safety Results from a Phase 2 trial of Risankizumab, a selective IL-23p19 inhibitor in patients with active psoriatic arthritis by myself, along with Drs. Kellner and Morita and colleagues. This abstract was presented at the American College of Rheumatology meeting in November 2017. I selected this abstract to discuss because it reviews an IL-23 antagonist agent, Risankizumab, although not yet approved, but in the pipeline for treatment of patients with PsA. We are learning that the IL-23, IL-17, Th17 cell axis is especially important in psoriasis and PsA, as previously demonstrated with the IL-12/23 inhibitor ustekinumab, the IL-17A inhibitors secukinumab and ixekizumab, the IL-17A and F inhibitor bimekizumab, the pure IL-23 inhibitor guselkumab, and now a newer pure IL-23 inhibitor, risankizumab. In this phase 2 study, risankizumab significantly improved joint and skin symptoms in patients with active PsA. It was well tolerated with no new or unexpected safety findings and underscores the continued effort to provide additional treatment options for PsA. In this 5-arm study, 185 patients with active PsA were randomized to receive risankizumab in an ongoing double-blind parallel design dose-ranging phase 2 study. There were several different dose arms, including 150 milligrams at weeks 0, 4, 8, 12, and 16, 150 milligrams at weeks 0, 4, and 16, 150 milligrams at weeks 0 and 12, 75 milligrams single dose at week 0, and or matching placebo. Patients were stratified at randomization by prior anti-TNF use and concurrent methotrexate use. Baseline demographics and disease characteristics were similar across treatment arms. The median age was 51 years, 43% were female, and 49% had psoriasis covering greater than or equal to 3% body surface area and thus could have PASI scores. The primary endpoint was ACR20 response at week 16. Additional efficacy endpoints included ACR 50 and 70, minimal disease activity assessment, DAS28 by CRP, dactylitis count, spark enthesitis index, pain, and HAQ-DI. What were the key findings? At week 16, ACR20 responses were significantly greater in patients receiving risankizumab across all arms, 57 to 65%, compared with placebo at 37%. ACR 50 responses were numerically higher. Improvement in HAQ scores and enthesitis from baseline were numerically greater in risankizumab arms. At week 16, risankizumab treated patients achieved significantly higher ACR 70 and minimal disease activity responses, as well as greater improvements in DAS28 and pain VAS. Treatment emergent adverse events were comparable across treatment arms. The most common was infection. There were no deaths or cases of TB in risankizumab treated patients. As lead author, here are my thoughts and analysis of this study. Risankizumab is one of 3 pure IL-23 inhibitors that are advancing in psoriasis and PsA. These agents work by interacting with the p19 subunit of IL-23, preventing receptor activation and thereby disrupting the IL-23-IL-17 axis. This trial is the first demonstration of risankizumab effectiveness in PsA, with multiple arms studying different dose frequency regimens. All doses and dose frequencies worked equally well, including the 75 milligram single dose arm. The drug in each of the dose arms and frequency was effective, demonstrating ACR20 response with very good skin responses, as well as a good safety profile. This is a proof of concept study. IL-23 inhibition is an appropriate target in the management of psoriasis and PsA. This study provides clinicians confidence in its use as this agent moves into phase 3. We know from this study that risankizumab works and has a good safety profile. Provided continued study results remain constant, it will share the stage with the IL-23 inhibitor ustekinumab, as well as other pure IL-23 inhibitors such as guselkumab, as well as the IL-17 inhibitors.